In this companion presentation to the written chapter entitled Indications and Techniques for Cranial Decompression After Traumatic Brain Injury, I will discuss many of the underlying reasons that the evidentiary basis for decision-making in clinical settings has been difficult to define, as well as recommendations made by various expert groups and through the summation of the literature and the author's experience. Tools are only useful when employed for their intended purposes. The question for decompressive craniectomy as a tool is what is its best intended use? To reduce mortality, for sure, but also to improve outcomes in those surviving this devastating injury. The procedure has undergone an evolution over time with respect to our understanding of when, why, and how to use this surgical approach to achieve good outcomes after TBI. As in everything neurosurgical, decision-making is driven by patient characteristics, examination, radiographic findings, and individual patient physiology. There are certain predictors that can be counted upon in the setting of primary decompression, defined as leaving the bone flap out when emergently evacuating a compressive mass lesion. Use of DC in this scenario will aid in the survival of the patient and promote an environment in which good outcomes can occur by reducing the secondary damage imparted by prolonged intracranial hypertension and cerebral ischemia. Midline shift out of proportion to the thickness of an extraaxial hematoma, compressed or obliterated cisterns, hemispheric ischemia, a massively compressed hemisphere, and signs of venous congestion are all radiographic predictors of postoperative cerebral edema that will likely result in prolonged ICP elevation if the bone flap is replaced. When these factors are present in isolation or combination, it is best to plan a very large craniotomy in anticipation of leaving out the bone flap. The appearance of the hemisphere at surgery is another important consideration when making this decision. When the brain is swollen and extending significantly outside the confines of the cranium despite medical therapies, the bone flap should generally be left out. The swollen and hyperemic brain shown here is one such instance. The use of secondary decompression is somewhat more controversial. In general, the findings listed here may argue for its utility because refractory ICP, poor cerebral perfusion, poor brain tissue oxygenation, loss of autoregulation, neuroworsening, and evolving mass lesions all portend a poorer prognosis. In considering secondary DC, the definition of maximal medical therapy and timing issues are of critical importance. While hypothermia has held promise as a neuroprotective strategy in TBI as in other pathologies, clinical trials have failed to show the benefit. While this could be due to methodological issues with some benefit still possible, it is generally accepted that it should be reserved for research settings at the present time. However, there is ample evidence for the importance of controlled euthermia and avoidance of fever. The use of phenobarbital coma has become less prevalent given the tendency for it to cause hypotension, a significant secondary insult, the requirement of ongoing bedside continuous EEG, and difficulties in pronouncing brain death. However, there is a role for phenobarbital in individualized therapy, most notably in patients with hyperemia through its effect on reducing cerebral metabolic demand, and test doses may be employed to gauge responsiveness prior to implementation of fully induced coma. Now that we have discussed the general indications and alternatives, let us address the rationale for utilizing this surgical technique. In the 1980s, the multicenter data registry called the Traumatic Coma Databank collected significant amounts of data on severe TBI patients and resulted in numerous publications regarding prognosis, outcomes, and physiology of TBI. Direct correlations were noted between unreducible intracranial hypertension and poor outcome. Whether ICP was causative of poor outcome or merely indicative of more severe levels of injury in which ICP could not be controlled with medical interventions, the correlation was dramatic and undeniable. Furthermore, the total time over which the ICP was greater than 20 also correlated with worsening outcome. It has also been observed that the incidence of ICP elevation requiring therapy in severe TBI patients is common, at 65%, a potent argument for the utilization of monitoring when able. Other findings from the TCDB were that the degree of midline shift was inversely related to outcome. The more shift on initial CT, the worse the outcome. Certainly, the presence of mass lesions, particularly if evacuable, affect this relationship. Furthermore, compressed or absent basilar cisterns also portended worse outcomes. The underpinnings of the ICP and outcomes relationship are described in the Monroe-Kelly hypothesis, which states that the brain resides in a closed container, the cranium, in which the main contents are brain tissue, cerebrospinal fluid, and blood, and any increase in volume of one component without a concomitant decrease in volume of another will result in an increase in ICP. The ability of an organ to control a constant rate of blood flow for metabolism despite variability in perfusion is called autoregulation. Cerebral autoregulation may be surpassed or lost at certain points after a TBI. This will be evidenced by parallel increases in ICP with blood pressure and can be tested at the bedside. If the volume of brain increases due to edema and there is no reduction in blood volume or CSF, the pressure will eventually increase. If CSF outflow is obstructed and accumulates in the ventricles, the pressure will also increase. If a mass lesion displaces any elements, pressure will increase. The relationship of intracranial content, volume, and pressure is represented above. When pressure starts to steeply increase on this pressure-volume curve, only small volume reductions are necessary to see fairly dramatic drops in pressure, which is why small amounts of CSF removal are effective at decreasing ICP, and while small volume increases, for example, in the setting of hyperemia or expansion of mass lesions or CSF obstruction, can be so deleterious when a patient is living on this end of the curve. It is therefore critical to understand where the patient is on a continuous basis when making decisions about the proper treatment modality to employ. The reason that decompressive craniectomy works is straightforward. When medical modalities to reduce blood volume and cerebral edema or to reduce cerebral metabolic demands and reductions in CSF volume via external drainage all fail and surpass the brain's ability to control ICP, the solution is simply to increase the size of the compartment. This has been repeatedly shown to be effective in ICP reduction and therefore enhancement of cerebral perfusion. Given that time and elevation of intracranial pressure is correlated with poor outcomes and decompressive craniectomy is effective at controlling ICP, it stands to reason that it would be an effective treatment for improving outcomes. However, questions remain regarding proper patient selection, the optimal timing and performance of the procedure, namely, how high should the ICP be allowed to be for what duration of time, the definition of failed medical management, and most importantly, for those who undergo the operation and survive, what will their prognosis ultimately be? These are incredibly complex questions to answer, first and foremost because many challenges related to the study of severe TBI patients in general. To begin, our abilities to prognosticate in severe TBI are poor in the very early phases of resuscitation and treatment. Clinical and radiographic information help, but remain limited as early tools to aid in decision-making. There is significant heterogeneity in presentation of patients with GCS scores falling in the severe category. The ability of any clinician to predict outcome on day one and for many days afterwards is often poor, when many decisions regarding DC and other treatments must be made. Addition of radiographic information to clinical data points in an algorithmic fashion has been attempted and has improved this ability, but it still remains limited. Many very experienced clinicians would have assessed this pre- and post-op scan in a patient presenting with a severe injury as predictive of very poor outcome, yet she ultimately had a barely discernible deficit and returned to work 8 months post-injury. While this is anecdotal, it is illustrative of the limitations on overall prognostic abilities for this injury. Care must be taken not to instigate a self-fulfilling prophecy of poor outcome by failing to be aggressive enough and to use the tools in our armamentarium, including surgery. Most readers will be familiar with the impact of the various factors listed here on prognosis. What is less clear is the impact of our interventions downstream of presentation and how they can overcome some of these prognostic indicators. Every neurosurgeon has had the experience of patients presenting in extremis with unreactive pupils and reversing the course by surgically addressing the problem. The question is, which constellation of findings represents, in any given patient, the limit of futility? Making the scenario even more difficult are yet to be elucidated impacts of genetic and epigenetic factors, which are suspected to be quite important. Secondary insults after injury play a key role in prognosis. Any single instance of hypotension or hypoxia affecting the already compromised injured brain will increase the odds of death and disability, and the two taken together have a major effect. Given that the injury itself often results in breathing cessation for at least some period of time, hypoxia is commonplace. Blood loss from polytrauma and other pathophysiological causes of lowered cerebral perfusion are also commonly seen in severe TBI patients. Therefore, identifying and correcting these events as soon as and as continuously as possible is critical. There are some findings on initial CT that correlate with outcome. The simple presence of subarachnoid hemorrhage resulting in worse outcomes was a finding from the TCDB in the 1980s, when the quality of CT scans was such that significant SAH had to be present to be visible. This would be associated with more diffuse brain injury. However, on modern CTs, even tiny areas of SAH are detectable, so the mere presence of SAH is no longer thought to be that significant. Diffuse, thick, disseminated SAH is, however. Midline shift and cisternal compression, as well as significant lesion volumes, have fairly obvious connotations. Subsequent CTs can demonstrate ongoing development of edema, efficacy of CSF drainage, or lack thereof, and progressive infarction evidenced by loss of gray-white matter differentiation. It is important not to interpret early hypodensities as infarctions in trauma, because they may simply be areas of edema that are reversible. Some have, as a result, advocated for the use of early MRI as a prognostic aid. However, early MRI in severe TBI patients is not only not a proven prognostic indicator, but it is significantly risky to patients. Remember the impact of hypoxia and hypotension on outcome, both potential risks of transport, not to mention ICP elevation due to prolonged need to lie flat in the scanner. There is some utility to MRI in that areas of damage or hemorrhage are better delineated with advanced techniques such as diffusion tensor imaging and susceptibility-weighted imaging. However, interpretation of findings vis-a-vis long-term outcome is not supported yet by data, due to selection bias for study, scan technique variability, and most importantly, the presence of reversible changes such as those of ischemia. Recent studies of MRI in DAI patients noted that MRI findings were not predictive of functional independence measure, Glasgow Outcome Scale score, quality of life, or even survival after TBI. As many as 62% of patients in another study had favorable outcomes despite findings of DAI on MRI. Using MRI in the research setting to help answer these questions is encouraged, but MRI should be interpreted with extreme caution as a prognostic indicator in the early days after TBI for clinical decision making. Correlation with large clinical data sets may be useful as MRI studies accumulate. Strategies to decrease risk must be employed, and further research is needed to help make this a relevant tool on which to base critical decisions, such as employing less aggressive or even withdrawing care. In addition to these difficulties in prognostication, there are further challenges inherent in the conduct of clinical trials research in TBI. Firstly, let us address variability in patient characteristics. Many TBI trials have sought to achieve sufficient power by inclusion of patients based primarily on GCS scores. However, many blunt TBI patients have a variety of other injuries that can ultimately impact outcome. Those obvious confounders such as concomitant spinal cord injury are generally excluded, but solid organ injury and in particular lung injury can have myriad effects on outcome, including mortality, even in otherwise young, healthy patients, as just one example. Add to this the many deficits that can occur with damage to craniofacial structures, such as loss of special senses, balance, vocal and swallowing problems, communication issues, and psychosocial problems from complex facial injuries. These can profoundly impact long-term recovery, in addition to risk of infection from CSF leak and various physiological disturbances associated with brain and polytrauma. These types of findings are generally neither controlled nor assessed in terms of impact on functional outcomes measures separate from the actual brain injury in clinical trials. While studies often use clinical criteria and a whole host of radiographic abnormalities as inclusion criteria, few large-scale clinical trials have correlated anatomical location of brain injuries from radiographs to their functional anatomical correlates to parse these effects on outcomes specifically. Patients enrolled by GCS criteria and a laundry list of intracranial findings such as those shown here would all be expected to have similar outcomes, yet clearly they will not. Trials must employ more refined inclusion and exclusion criteria to account for the various radiographic findings that can lead to severe TBI and coma. Even the interpretation of images can vary amongst individuals. through incorrect measurement of midline shift, properly measured for its effect on prognosis at the level of the anterior commissures. The degree of midline shift at different locations may depend upon the location and configuration of extraaxial and intraaxial hematomas. Measuring too high, too far anteriorly or posteriorly may significantly alter midline shift measurements, and when quality control measurements are made in the setting of clinical trials, they are performed ex post facto. Furthermore, checking accuracy and precision on these types of measurements is extremely time-consuming in a clinical trial, and therefore usually done only via sampling methodologies. The utilization of machine learning to perform such measurements would be advisable in future. Finally, in all trials of TBI, even those not specifically studying a surgical technique, there are going to be operated and non-operated patients, and the operated patients have no controls placed upon the techniques utilized. This introduces an incredible amount of variability into any such trial. In terms of decompressive craniotomy techniques alone, this list of basic steps in the decisions and operations involved can impact ultimate outcomes. Not the least of these is the DC technique itself, and longer term, how various surgeons handle CSF absorption problems and diversion needs. Many surgical trials set requirements for the level of skill and experience of the operator. This would be next to impossible to do in a general TBI trial, but does influence outcomes. This requirement should be considered in any trial specific to a surgical intervention. Complications can occur as a result of poor technique, skewing trial results, as well as from variable follow-up and many other perioperative management issues. In general, from DC, as discussed in the chapter, complications fall into three broad categories: those due to soft tissue and bony anatomical structures, those due to CSF dynamics, and those due to primary brain dysfunction. The variability inherent in management of all of these across a multicenter trial, when not controlled, can deeply impact the results. Perhaps on a par of importance with surgical management in terms of heterogeneity is that inherent in critical care management of TBI patients. Neurocritical care management involves multimodality neuromonitoring, invasive continuous physiological monitoring, and many variables, avoidance of complications of immobility and metabolism, and the treatment of the most complex insult to the most complex organ and the most complex environment in medicine. This schematic illustrates the molecular pathways involved in a rotational head injury leading to a mild TBI. Considering this and many other pathophysiological cascades involved in a severe TBI, questions arise regarding neuromonitoring decisions we must regularly make in the ICU. In general, one must consider that more neuromonitoring should be being done, not less, in order to help guide these complex decisions. Understanding which patients will benefit from which monitoring measures is important so as to conserve resources, but deploy them to those with injuries in which they can actually guide interventions, including decompressive craniectomy. In the setting of clinical trials, these decisions are generally left to clinician judgment beyond basic ICP monitoring, unless the monitoring is the subject of the trial itself. Once again, variability is introduced and may not be controlled in the randomization process because these variables are typically not analyzed. Tools do exist to help monitor various important physiological parameters continually after a severe TBI and can be employed in clinical trials methodologies. Provided the most severely injured are monitored with the readily available measures of ICP and brain tissue oxygenation and derived cerebral perfusion pressure. This schematic represents all of the various combinations of values that could occur at any one given time, the intervention for each of which would logically be different. One also must continually assess the impact of various interventions employed on each scenario to really make good decisions about the next intervention and the next, including the right use and timing of DC. Without specifically analyzing the combination of events and trends in a clinical trial, important conclusions could be missed. So, even though these parameters may not be thoroughly analyzed in trials, we still must utilize the information available based upon well-established physiology to make clinical decisions. This isn't done in a vacuum, either in time or space, and definitely not without involvement of the many teams involved in a severe TBI patient's care. Continuous, ongoing assessments of the patient's progress are required to know the optimal time that surgical decompression might be needed. Again, autoregulation is an important aspect of management of ICP and cerebral perfusion as a surrogate for cerebral blood flow. It can be tested at the bedside, and its presence or absence at any given time can be used to drive therapeutic decisions. Troubleshooting is a regular part of the ICU management of TBI patients, and the medical therapies employed to manage primary brain injury listed here should be continuously assessed for their appropriateness and utility. Understanding where the patient is at all times with respect to all of these parameters informs the decision for DC, including timing. Maximal medical therapy includes each of these parameters. Laboratory data must be frequently employed to assess maximal medical therapy status as well. For patients presenting with acute ICP elevation after a TBI, the above lab evaluation represents the starting point for assessment of overall status, including the exam, radiography, and physiological status. The ICP waveform can provide a wealth of information regarding whether or not to operate. Again, waveform analysis is not commonly employed in research protocols unless they are a specific target of the protocol, but they can play a major role in all forms of decision-making for treatment. Intracranial compliance determines the ability of the intracranial compartment to accommodate an increase in volume without a large increase in ICP. Poor compliance, or high elastance, occurs in the steep portion of the pressure-volume curve reviewed earlier. The typical waveform for poor compliance in the setting of high ICP and the setting of maximal medical therapies and CSF drainage suggests benefit from surgical decompression. These complex interactions highlight that the management of these patients should not be episodic. Patients should have clear goals of continuous physiological management that are well understood and communicated amongst all critical care teams, and endpoint triggers for DC should be anticipated, prompting surgery when those goals are no longer met. Further challenges in TBI trials revolve around outcomes assessments that are at the same time achievable with a challenging patient population, have high inter-rater reliability, are as objective as possible, and are sufficiently sensitive to detect functional differences. Trials in TBI and other neurological diseases can sometimes suffer from less than ideal outcomes measures that may not be granular enough to detect meaningful differences. The Glasgow Outcome Scale, or GOS, and the Glasgow Outcome Score Extended, or GOSE, have been the standards for TBI research and have significant utility. However, even these measures have some degree of subjectivity introduced in the assessment phase, and patients can have very broad functional outcomes, even within category. More importantly, the patient's value system needs to play a role in decision-making because one person's good is another person's poor outcome. This is no more evident than in the category on the GOSE entitled Upper Severe Disability. These categories were developed in order to have some metric that was comparable across numerous patients. However, is someone who can be left alone for 9 hours really that much better than someone who can only tolerate being left alone for 7 hours? The test is done by a trained examiner who attempts to use the best source of information for each aspect of the questionnaire, and as such, some degree of subjectivity is introduced. Take, for example, this theoretical patient who has suffered a severe TBI. This man would be classified as an upper severe disability patient due to his inability to navigate transportation outside his home. He would arguably have a good outcome after a severe TBI, yet prior convention would have included him in the poor outcomes category. This level of disability correlates with other neurological scales that are typically dichotomously classified as good outcome, for example, the modified Rankin score used for stroke studies. Many TBI studies have therefore employed a number of other assessments of function in addition to the GOS or GOSE, including but not limited to formal neuropsychological testing. Any study of TBI should consider the importance of patient-reported outcomes measures. While physicians and scientists have expertise in various objective assessments of function, we must include the patient's own level of satisfaction with their status, as well as their families. Such satisfaction depends on a variety of cultural, societal, and individual belief systems, and necessarily varies over time as patients evolve and adapt to their post-TBI challenges and quote-unquote new normals. It is on this background of TBI trials challenges that 2 large surgical trials have been attempted within the past decade and a half to address the utility of DC for treatment of TBI. While much has been written and numerous retrospective and prospective studies have been performed in the past 6 decades, there have only been these 2 large randomized prospective trials published in the modern era. The DECRA trial. The DECRA trial, published back in 2011, studied a very small subset of TBI patients, namely those with diffuse edema and no mass lesions. This study demonstrated, somewhat incongruously, that patients had better control of ICP and shorter ICU stays, but had more unfavorable outcomes. We will delve into some aspects of the study design that may explain this phenomenon. Surgical technique standardization and crossover issues commonly plague such trials. Furthermore, in the DECRA trial, the population of interest was purposefully quite specific, but resulted in a lack of generalizability to most severe TBI patients who don't fit this definition. Other issues could have affected the results as noted here, but probably most important was the definition of refractory ICP, both in degree and in duration. The Rescue ICP trial. The Rescue ICP trial studied patients with TBI and refractory ICP without ruling out mass lesions and concluded that DC lowered mortality and rates of upper severe disability at 6 months, but of concern was the reported higher rate of vegetative state and lower severe disability. Similar rates of moderate disability and good recovery were seen. However, at 12 months, outcomes were improved over 6 months, in contrast to studies a few decades ago that argued for 6-month outcome as a good surrogate marker for 12-month or longer-term outcome. Furthermore, there are several other important key takeaways that we will discuss. This study used the Glasgow Outcome Scale Extended as the primary outcomes measure. However, in the dichotomized GOSE, a score of 4 was categorized differently than past TBI trials had done to reflect a more realistic assessment of functional outcomes. Those with upper severe disability are largely independent in the home and may need assistance with certain activities like traveling or shopping, as previously discussed. By contrast, lower severe disability patients are generally confined to an institution or require nearly continual support at home, making this breakpoint more logical. This categorization is also similar to the modified Rankin scores typically used in stroke studies, as previously mentioned. The investigators concluded that surgery lowered mortality, but that there were also higher rates of vegetative states and lower severe disability. On the other hand, the percentage of those with upper severe disability or better was greater in the surgical group. At 12 months, overall outcomes were even better than they were at 6 months in the surgical group, demonstrating that ongoing improvements take place over time if patients are afforded survivability. So the Rescue ICP trial studied patients who are more commonly encountered in clinical practice than DECRA, including those harboring mass lesions. The trial's design was quite a bit different, namely that a more widely accepted definition of refractory ICP elevation was used. This study did allow for some clinician discretion, significantly, in surgical technique. Both trials demonstrated some key challenges in surgical trial design, the first to be discussed being the definition of refractory ICP, including the question of what degree and duration of high ICP should be tolerated before intervention. While DECRA enrolled patients with minimally elevated ICP for very short periods of time without a great deal of medical therapy being employed, the Rescue ICP trial utilized a more widely accepted definition of high ICP and more extensive medical therapies prior to randomization. Further, the Rescue ICP trial included randomization for 10 days after injury, contrasted to DECRA, which used 72 hours from onset of treatment for ICP as the time window. These two studies were classified in a subsequent guidelines effort as providing early and late intervention, but these populations were different, the degree of medical management was different, and the extent of ICP elevation was different, so comparisons between these two trials should be approached with caution. Given the relative rarity of severe TBI, enrolling sufficient numbers of patients to achieve statistical power for such trials often tempts people to compare one trial to another, but dissimilarities in trial design limit justifiable comparability. Surgical trials are also challenged by technique standardization. In the Rescue ICP trial, differences in technique were utilized. Decompressions could be unilateral hemicraniectomy or bifrontal based upon surgeon preference. Since most of the patients were enrolled in Europe, where the bifrontal approach is more commonly employed, around 2/3 of the patients were approached in this manner. However, in the US and other geographical areas, hemicraniectomy is far more commonly used. Care must therefore be taken in the interpretation. There may well be differences that would be detected, amplified, or ameliorated if the same technique had been used throughout. Crossover from one therapeutic arm to another is utilized in many surgical versus medical therapies trials. This is sometimes driven by ethical considerations. However, the biostatistical imperative of intention to treat analysis techniques can completely confound the interpretation of results when crossover is done too liberally. Many have advocated for as-treated analyses to be employed in such trials instead. Rescue ICP was not exempt from this commonly encountered obstacle. Over two-thirds of the medical arm patients failed therapy and crossed over to surgery. Perhaps tellingly, only 9% of the surgical group failed ICP control. Certain things can be well accepted, and the conclusions of Rescue ICP have been mirrored throughout the literature in numerous other studies, albeit not necessarily randomized prospective ones. Surgery has been shown repeatedly in DECRA, Rescue ICP, and many other reports to be effective in the control of ICP. Likewise, numerous studies have shown that medical therapy alone is often not adequate in these patients for ICP control. Given that absent ICP control, mortality risk is significantly increased, it is not then surprising that surgery lowers mortality. The question is whether or not that survivability can result in better functional outcomes and patient and family contentment with the deficits. It is critical to discuss patient wishes when making these decisions, and it is also critical not to stop short of long-term and ultra-long-term outcomes assessments. Given these challenges, it is not surprising that many have advocated for as treated as opposed to intention to treat analyses, as well as other methods of study, including analysis of real-world prospectively collected data sets using propensity analyses. The definition of complications in any future trials needs to be rigorous and should be built upon best available data on incidence in non-surgical patients. Furthermore, they should be considered in the context of other interventions employed in medicine and what acceptable complication rates should be. This can only be done with further data acquisition. Suggested improvements for future surgical trials would include attempts to align technique and experience amongst enrolling surgeons, independent radiographic assessments, potentially including artificial intelligence modalities, and more objective methods for assessing complications. While the DECRA and Rescue ICP study groups should be commended for studying this important clinical question, the trials do call up some significant challenges that are inevitable in any surgical trial, especially in a surgery versus medical therapy design. While also helping to elucidate potential solutions for future study, this will take significant time and resources, leading many expert groups to seek alternative guidance from neurosurgeons. The Cambridge Consensus Conference. In an effort to address some of these important questions, a consensus conference was coordinated by Peter Hutchinson and colleagues in Cambridge in 2017. The results of this conference were published in 2019 and included a statement that there is a role for DC in TBI. This conference convened numerous TBI experts from 6 continents for 2 days of directed panel discussion in an iterative process to achieve consensus as outlined here. Thresholds of agreement were set in order to either accept or reject certain statements, all of which were published. Issues addressed included primary DC in the face of mass lesions, secondary DC for established refractory ICP elevation, surgical techniques, perioperative care, bone flap replacement issues, and use of this technique in low and middle income countries. I will address only numbers 1 and 2 at present and will touch on surgical technique a bit later. For other findings, I refer this audience to the original document. These conclusions are represented in the manuscript and in my slides according to the percent of experts in agreement with the statement, with raw numbers of participant votes also being noted. Given the outcomes differences for evacuated acute subdural hematoma and epidural hematoma, these entities were considered separately. For acute subdural hematoma, as noted earlier, a bulging brain outside the inner table should prompt consideration of leaving the bone flap out. There was 100% agreement on this statement. Conversely, if the brain is very relaxed and preoperative imaging had none of the central or cardinal features listed earlier, the bone flap should be replaced. For intermediate cases, the surgeon must use his or her judgment. Bone flaps should be replaced in the case of evacuating an isolated epidural hematoma. Whether or not the bone flap is replaced an ICP monitor is recommended to follow and treat ICP in the perioperative period. In situations where ICP monitoring is not available, frequent CT scanning and examination may be used to monitor progress. Clearly, the bone flaps need to be large. DC is thought to be an option for patients with contusions, but for whom no evacuation of the contusion is planned, such as mixed density contusions. Surgeon judgment should be used to decide whether discrete, well-formed hematomas should be evacuated, and the location of these hematomas is often operational in this decision. Once again, as with primary DC, a large decompression is necessary, and surgical approaches include bifrontal or hemicranial options. Since most patients have some lateralizing lesion or some degree of midline shift, my opinion is that a hemicraniectomy is the approach of choice for most patients because it is effective at holohemispheric decompression and have a lower complication rate. Even in those in whom no lateralizing signs are present, a non-dominant hemispheric decompression can be quite effective. While it is clear that secondary DC lowers ICP, other factors contribute to the overall outcome, including lesion characteristics and other pathophysiological phenomena. Therefore, the optimal candidate for decompression is a patient in whom it is thought that the main contributor to a potentially poor outcome is intracranial hypertension. Other radiographic signs and history and physical findings should be compatible with acceptable recovery, with the caveat that even these as clinical predictors possess some degree of uncertainty. Interpretation of the totality of the patient's presentation often takes precedence over individual prognostic factors. Future studies should attempt to further delineate the prognostic power of various findings in combination with one another. Again, ICP monitoring, CT scanning, and neurological examination are critical elements in the management of secondary DC patients, as well as primary. It is clear that simple ICP thresholds alone are not sufficient to determine a patient's eligibility for surgery. Sustained refractory ICP elevations, along with numerous other clinical parameters, must be taken into consideration. As with primary DC, it is important to continue monitoring ICP even after decompression, as secondary crises can occur and monitoring can guide further therapeutic interventions. There's uncertainty about which subgroups of severe TBI patients will benefit from this operation, as we've discussed. In addition to potentially contributing to poor survivorship, there are, as with any major operation, complication risks and concerns. Frank discussions about the uncertainty, the risks, benefits, alternatives, and potential prognosis should be undertaken at the time. A word or two on a few related recommendations. Similar to the consensus conference findings, a recent Cochrane review concluded that there is promise for this procedure, but that much is yet to be learned regarding patient selection, timing, surgical techniques, and synergies with other treatments. As mentioned earlier, an update to the evidence-based TBI guidelines came to similar conclusions. This guideline further stated, largely based on the two trials discussed, that early refractory ICP should not necessarily prompt a secondary decompressive surgery. However, my comments about degree and duration of elevation and time from injury should also be noted. The guideline did acknowledge that secondary decompressive surgery for late refractory ICP is recommended to improve both mortality and favorable outcomes. The definition of short-term and long-term outcomes is an extended one for severe TBI. In the first year after injury, not only is there ongoing pathophysiological recovery, but numerous other events are occurring. For those who sustain polytrauma, healing and recovery from multi-systems injuries, tracheostomy, and other procedures affect mortality and function. Rehabilitation efforts and resources may be quite variable in this period. In those undergoing decompressive surgery, events such as bone flap replacement and other downstream procedures like shunting for hydrocephalus affect not only the ultimate outcome category, but the trajectory of recovery in those first 12 months. Recall the finding in Rescue ICP that 12-month post-surgical outcomes were better than those at 6 months. This recent rehabilitation study further demonstrated that the use of DC was associated with good health-related quality of life up to 10 years post-injury, highlighting the ongoing nature of recovery. Finally, I would like to touch on the impact of surgical technique on subsequent brain damage, recovery, and functional outcomes. As in any aspect of neurological surgery, meticulous technique will achieve better results. Appropriate planning at the time of the trauma craniotomy will avoid many complications. The skin incision should always be outside the planned craniotomy and should not be placed directly on the border of the pinna. The flap, once again, needs to be large, and the craniectomy must extend all the way to the middle fossa floor in order to adequately decompress the temporal lobe and to undo and prevent uncal herniation. The dura should be opened to relieve ICP and should not be primarily tightly closed without a duroplasty to expand the dural pocket and allow unrestricted swelling. Avoidance of galeal adhesions to the cerebral tissue is a key step in the primary surgery. Various options for skin incisions exist. For hemicraniectomies, the options include a large curvilinear incision extended from behind the ear, but this makes exposure to the base of the temporal fossa and reoperation difficult. The teat incision with parasagittal and vertical temporal components has been often employed by the military as a rapid access incision for damage control, but has the disadvantage of a three-point junction distal in the scalp blood supply distribution. I favor a question mark or reverse question mark incision as preservational for blood supply and optimal for access to the temporal fossa. For bifrontal decompression, a standard sutar bicoronal incision with a widow's peak is employed. Soft tissue injuries often dictate modification of a standard incision. The craniotomy must be large and must employ temporal craniectomy to the floor of the temporal fossa with flattening of the sphenoid wing ridge to avoid strangulation of brain tissue. Take care to plan the bone cut off of the midline to avoid the superior sagittal sinus. Demonstrated here is the temporal craniectomy with rongeurs, which should be done prior to opening the dura if possible, so as to avoid secondary tissue damage. If the durotomy must preclude this to release, for example, an acute subdural hematoma, perform the durotomy higher up and remove pressure of the hematoma, then perform the craniectomy, returning to the full durotomy to the temporal fossa floor only after the bony removal has been completed. Generally, I will attempt to gently lift the temporal lobe off of the tentorial incisura to deherniate the uncus. Similar to this, cisternostomy has been reported as an adjunct to DC. This interesting paper describes this technique, which aided in achieving favorable outcome. There has been considerable controversy over the extent to which dural grafts should be sutured. Regardless of the technique used, the surgeon needs to ensure that the graft utilized will not migrate. Additionally, redundant tissue grafts should be avoided due to previously described effects of even small volumes of extra tissue contributing to ICP problems if the patient remains in a poor compliance situation. Finally, division of the falx cerebri as an anatomical untethering is recommended to release tension along the midline and pressure in the face of a bifrontal decompression. Numerous materials are available for creating duroplasty pouches. I prefer material that is suturable, handles similar to native dura, and will incorporate into native dura over time. Demonstrated here is my personal technique for avoiding secondary injury in the postoperative period up until the time the bone flap is replaced. I generally create a sutured duroplasty in order to avoid graft migration and provide optimal brain protection. While a watertight closure is not necessary to achieve, what is necessary is to avoid the inevitable galeal adhesion directly to cortical tissue and draining cortical veins that will occur with exposed brain to galea. Galeal adhesions can result in venous infarction, edema, and cerebral tissue loss at reoperation and before. This technique of duroplasty pocket and barrier formation also allows for potential improvements in hemostasis, avoidance of subgaleal oozing blood coming into contact with already injured brain tissue, and protection of the brain from subgaleal drain fenestrations as drains are being pulled across the surface during removal. I favor a graft material that will integrate with native dura over time, as stated. At a minimum, an onlay graft between the brain tissue and the galea has been recommended by the consensus conference group. The square white graft material in this illustration is a non-integrating barrier graft placed over the dura and in the subtemporalis plane. This prevents the temporalis muscle from adhering to the underlying dura and graft and allows for rapid and easy dissection without traction or heat transfer at the time of bone flap replacement. This is subsequently removed and discarded. Contrast the prior images to this patient of another surgeon who I reoperated for a postoperative extraaxial hematoma. The patient had had numerous dural incisions and flaying of the dura, with a few pieces of onlay graft that had been completely displaced by either drain removal or dissection by the post-op hematoma. You can see here the large cortical surface area that was in contact with the galeal surface. The hematoma and galea were already significantly adherent to the brain tissue and draining veins, even early post-op, and most assuredly this would have caused long-term adhesions during healing had not the intercurrent operation for the post-op hematoma been done. In this case, after evacuation of the subgaleal hematoma, grafts were placed with the new subgaleal drains for hemostasis, and the brain was protected by a new onlay graft that was loosely sutured and tacked into place. Secondary bone flap replacement. Issues of bone flap replacement include material, timing, and intercurrent recommendations for activity. Early replacement is now largely defined as within about 12 weeks. This facilitates rehabilitation, protects the brain from further injury, and avoids the syndrome of the trifine in many cases, as well as helping with a variety of other issues delineated here. This must be balanced with resolution of cerebral edema and understanding of the CSF dynamics, as well as reducing risk of nosocomial infections related to various indwelling monitors and catheters required in the initial phases of TBI treatment. Meticulous wide hair clipping and prep are advisable in this population. Lumbar drains can be placed pre-op in the OR and removed post-op in the OR or during the same hospital stay if there is only mild fullness, but sufficient to produce concern about brain compression from the bone flap. This can be used to help determine any need for further CSF diversion as well by monitoring CSF output, correlating with the neurological examination and CT findings post-operatively. Tissue handling should avoid heat transfer to underlying previously injured brain tissue, especially the temporal lobe, which has nearly always been compromised. Given a high incidence and immediate postoperative seizures in our early cohort, we initiated utilization of a 7-day period of prophylaxis, beginning with loading dose in the OR, followed by standard dosing procedures. This has been well tolerated in a very large series of patients and reduced immediate postoperative seizure rates. There is often robust tissue thickening at the edges of the craniotomy, which can be sharply dissected away from the bone edge and even reduced in thickness using bipolar cautery if necessary. The temporalis muscle should be dissected off of the underlying dura for replacement into its anatomical location, taking care once again to avoid recurrent traction or heat transfer to the underlying temporal lobe tissue. The temporalis can be reaffixed to the bone flap or prosthetic using sutures or plates and screws. In fact, whenever possible, the temporalis muscle should be replaced into its anatomical location outside the bone graft or cranial implant. This avoids muscle contractions, causing traction on the brain and pressure for mass effect on the typically already damaged temporal lobe. It also provides for better comfort and cosmesis for the patient. A variety of synthetic implant materials are available for intraoperative construction or customized construction preoperatively. I prefer the customized PEEK implant for ease of handling, protection and durability, perforations to aid in drainage of epidural fluid into the subgaleal drain post-op, as well as to use for suture placement, and the ease of dissection if reoperation is ever needed. We can save lives, and we can help people to achieve the best life possible despite potentially devastating injuries. But this is about more than one operation or even one hospitalization. It is about knowing the patients in every sense and becoming a partner with them on their journeys to recovery. Given the complexity of decision-making and limitations in our evidentiary basis, what else can be done to improve life for our severe TBI patients by better understanding both severe TBI and this surgical technique? Advanced imaging techniques to define prognosis for very specific structural injuries and brain mapping will be beneficial. Included in these techniques are connectogram constructions for both within individual changes over time and population studies. It will behoove us to transition to innovative study paradigms such as large prospectively collected, well-defined registries with incorporation of imaging and biomarker data, as well as propensity analyses and other forms of advanced analytics, like machine learning for imaging and physiological data. Advancing surgical techniques worldwide can be done through didactic video and hands-on sessions. Advocating for surgical modeling and simulation in general will help ensure the surgical competence of future generations of neurosurgeons. In conclusion, what can we say about the use of this technique? There are many side questions related to decompressive craniectomy that have yet to be definitively addressed in the literature. With respect to decompressive craniectomy, clinical trials should inform us, but with the knowledge that they are challenging to conduct and to interpret. Certainly, there are a number of questions that can be studied and addressed with respect to prognostication, use of specific techniques, and refinement of outcomes assessments. Perhaps most importantly for this audience, I would emphasize that meticulous surgical technique is very important in the determination of ultimate outcome. We need ongoing refinement of proper patient selection and timing, as well as further understanding of true risks and the limitations of tolerability in patients and families. We need rigorous ICU management and refinement of our understanding of how to treat various physiological endpoints, as well as widespread education on this approach. When deciding whether to use decompressive surgery, it is important to treat the entire person, including taking into consideration polytrauma injuries, medical history, resuscitation events, personal values, and other factors that will impact on prognosis and quality of life. Obtaining meaningful outcomes is about so much more than one surgical intervention.